You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Let's talk hernias, specifically inguinal hernias. In adults, we're a little lax about them. In men, they're common, they're mostly reducible, and they're often a chronic problem. Surgery is mostly elective. Only if they're incarcerated or strangulated do we need to intervene. In children, it's another story, mostly having to do with epidemiology, likelihood of complications, and logistics. So, on this Focus On episode, let's talk inguinal hernias in children. We'll start with a quick anatomy refresher. The inguinal canal passes through the abdominal wall obliquely into the groin. In boys, the inguinal canal contains the spermatic cord, which passes from the abdomen into the scrotum. In girls, the inguinal canal contains the round ligament, which passes from the abdomen into the labia majora. The canal itself is a conjunction of the aponeurosis of the external oblique muscle anteriorly and the transversus abdominis muscle and transversalis fascia posteriorly. Intestinal contents that herniate through the inguinal canal results in an indirect hernia, indirectly traveling through the canal into the groin. Direct hernias occur when the intestines just flat out push through the abdomen itself. There's an area particularly prone to direct herniation called Hasselbalch's triangle. It's a vulnerable area of the abdominal musculature that's bounded by the inferior epigastric vessels, the inguinal ligament, and the rectus sheath. Most of the time, when we're talking about inguinal hernias, we're talking about indirect hernias, those that follow through the canal. We often think of the middle-aged, overweight man who lifted something heavy. This is the typical patient with an indirect inguinal hernia. Infants, however, are actually more prone to them. In infants, the inguinal canal is short. Its course through the abdominal wall is not quite oblique yet. It's more perpendicular. That means the external ring sits almost in line with the internal ring. Less force, less pressure is needed because the rings are more aligned in infants. Think of all that pushing and pooping and all those external and internal rings just waiting to get a loop of bowel through them. Just as a side note, if you intubate a small infant, especially a preemie, watch out for what that mechanical ventilation may do to his intra-abdominal pressures. And hernia watch on ventilated preemies is a thing. Another fun fact, most indirect hernias usually happen on the right. Why? Because the testicles originate in the abdomen, and because of the asymmetric relationship of the other abdominal organs, the left testicle usually descends first, and the processus vaginalis, through which it descended, is long obliterated. The right descends later, pulling with it that peritoneal outpouching called the processus vaginalis, using the meaning of vaginalis as sheath-like. The processus becomes the tunica vaginalis after descent and obliteration. It's just a light covering. So, left side is long situated when the right side descends, and sometimes the obliteration of the potential space never is completed, and you always have that laxity of the tissues. In girls, the processus vaginalis is called the canal of Nuck. Contents under pressure always look for least resistance, and so there goes the intestine down that potential space superhighway. And so you herniate through the canal, into the scrotum in boys, and into the labia majora in girls. Don't forget the girls. An inguinal mass in a baby girl may be her little ovary herniating into it. So a hernia all the same, but it's not the intestine. When an indirect hernia happens, again, mostly in boys, mostly on the right, and mostly in younger infants or possibly in the premature infant, it's either reducible, incarcerated, or strangulated. Reducible hernias will come and go with crying or defecating, and you may be able to gently reduce them. If you've had a hard time remembering the difference between incarcerated or strangulated, just think, which would you rather be? Incarcerated hernias are just the kind that have too much edema around them to reduce manually. We have to deal with them, but there's time. Strangulated hernias have so much edema that there is poor circulation now, usually poor venous drainage. So much so that they're at risk for necrosis. If there's enough ischemia to the bowel wall, there's perforation, and ain't nobody got time for that. If you were taking a test, for example, you may be asked about things like other associated conditions, like children with connective tissue disorders, for example, Ehlers-Danlos syndrome. Perhaps problems with the GU system also have some associations with hernias, like hypospadias, ambiguous genitalia, or even a positive family history of the same. Okay, you know all that stuff. Let's get down to the nitty-gritty of what it means to see an infant or small child with a bulge down there. It's not always a hernia. A hydrocele is painless, and it's a fluid collection. Hydroceles usually are non-communicating with the abdomen. They're usually worse with crying or during the day, they improve by morning, and they self-resolve by age 2 without intervention. Communicating hydroceles are usually present at birth. They're associated with a patent processus vaginalis. They're often repaired later if they don't resolve on their own by age 1 or 2. A varicocele is seen in adolescence, and it's just a bunch of dilated veins. Reassurance is all that's usually needed. Now, you wouldn't confuse a hernia with testicular torsion, but then again, why not? Both are painful. Both are often edematous. More history and a careful exam usually steers you in one way or the other to get the right diagnosis. Hernias often bulge further with crying. For infants in the supine position, you can gently restrain their feet on the gurney. They hate it and they will cry. For older children, have them laugh, cough, or blow through a syringe. You may hear some old school people talk about the silk glove sign. It's fine if you can elicit it, but it's not reliable. Roll the cord structures across the pubic tubercle. If you feel a catching, like 2 sheets of silk rubbed together, this suggests edema from the patent processus vaginalis. Now, you can always use ultrasound if you're unsure, but it's mostly a clinical diagnosis. In girls, I would push for that ultrasound only because you want to make sure that it's not her little ovary that's out of place. So, let's say you're calling this a hernia in a small infant or child, and another reason, by the way, is always to look inside that diaper of any child coming in to see you. You never know unless you look. So you see a mass in the right scrotum, and you want to try to reduce it. It's a hernia, after all. Now, we always worry about reducing necrotic material back into the abdomen, but I'm here to tell you that you aren't going to reduce an edematous, incarcerated, or strangulated hernia back into that abdomen in a child who is not under general anesthesia, so don't worry about that. How best to reduce the reducible hernia? So let me explain. We can give some, let's say, intranasal fentanyl, make them feel a little bit better, and we want to elongate the bowel contents toward us to make them want to retract back. We don't want to just mash on the bowel like a balloon animal. We want to elongate nice and comfortably and slowly, and we'll hold there and we'll wait until peristalsis says, gimme, gimme, and starts to pull back in the contents, and we can slowly hold less and less tension and allow them to go back in. Okay, so that didn't work. Or you know what? Maybe even if it did. Even if you were able to reduce the hernia, we still need to go further. Again, in adults, we can send them home even if the hernia is not reduced, as long as it's not completely incarcerated and, of course, not strangulated. The general vibe in adults is they do well, and if they don't, they'll be back for urgent or emergent surgery. We just don't play that game in children. Why? Well, first, it's not nice. But more importantly, it's dangerous. Unlike in adults, all hernias in children are repaired at the time of diagnosis because, first, the risk of incarceration and strangulation is higher in this age range. Second, there is a 30% risk of testicular infarction because of pressure on the gonadal vessels. And last, it's just not worth messing around and trying to have parents navigate the system. Most incarcerated hernias, about 80% of them, can be reduced initially and just admitted for surgery in 24 to 48 hours after the edema has improved. You can use age and patient-appropriate sedation and reduce it if there's no peritonitis or no concern for real ischemia there. Open repair or laparoscopic techniques are often used, and the laparoscopic technique offers visualization of the contralateral side without significant risk of injury to the vas deferens. There's also something called a metacrinous hernia. It develops later on the other side, and some surgeons will opt to explore both sides at the time of diagnosis. Some will take a more conservative approach because they worry about that small risk of fertility issues if both of them are open explored. My take on all of this, regardless of the presentation, these children with hernias need admission. So, in summary, indirect hernias are mostly in boys, mostly on the right, and sometimes associated with prematurity, family history, or other conditions. If you think this is a hernia, either by history and it's already reduced, or you reduce it yourself, get this kid admitted so that the surgeons can plan for urgent repair. It's just not worth playing around. Another Focus On episode for your quick review. Thank you for listening, and remember, until next time, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.